Yeah, but now more. Probably like 35,000. Plus questions, like including all the no, like it's literally the shortest thing. I'm figuring it out. It's literally like almost. Yeah, I was gonna message you and be like, oh, can you make sure it's really short? Like, he's having his favorite. Yeah, like he's having fun. He's like, you know what my favorite thing is? Do you remember were you there? Have you seen Facts on laptop? Oh my god. Yeah, I'm so bachelor. It took 15 minutes.
No, hold on.
Well, not really.
Why don't you put it on duplicate that? That's my try, I guess. Give it to him now. Wait, the recording video. Let's have a look. What is 10%? Let me see if there's any notes there. There's no notes. There's no notes. Because sometimes the lecture is short. There's no notes. Yeah, so we don't need that.
It's really close by. Like wherever you go will be close. Even barracks like a
You need to.
It's only 27 minutes.
Yeah.
So I actually have a research thing that I was supposed to go to.
No, not the mouse.
Oh, you should have to turn up at 6 p.m. today. I'm like, sorry, I am not and if you think I can make it from Monash to the afternoon in half an hour, even in a car, you must be doing it. So no, I am not whatever it is. It's just crazy. How does, I don't really know how to do this, but we're gonna go with it.
You just stop me.
I might just. Okay, just sit here, cross legs. Cool. I might just make a start. Is this working? Can you guys hear me? Oh, it is working. Guys, year 2. Oh, that worked. Okay. So yeah, I'm gonna make a start. Welcome to your lower limb revision lecture for 2017. For those of you that don't know me, my name is Shimoli, and I'm a 3rd year. Just a bit of background, I'm at Cabrini Hospital this year, which is part of the Central Clinical Schools. Come to Cabrini, it's a great place. And yeah, so yeah, let's make a start. So the way this is gonna work is I have food bribes, I have lollies. So please like answer questions, ask questions, and if you're too shy, ask at the end. And the way this is going to work, because I think it's probably better to like keep you awake this way, is that I'll give you a question, you'll try and answer it, and then the concept that's behind it will be after that. So this is a very, very short presentation because I just thought I'd distill everything down. I know you're probably panicking about other stuff and have other stuff on your mind at the moment, and lower limb is sort of feeling like the least of your worries. So that's why this is so short and really, really concise. And so hopefully this helps you. Yeah, also if you really, really do want to go back and learn everything, which some people prefer to do, just remember to learn it like logically And remember that it doesn't matter where the, like, I don't know what muscle sits and where it attaches, unless it's clinically relevant, unless something can go wrong with it, and unless it's like something that Monash is really focusing on, it probably won't turn up. So if you do want to go back and learn everything, just sort of maybe pick and choose what you're doing, because there's not like that much time left. Cool. So I just put this in quickly as a refresher for not just you, but for me. And oh, is this a mouse? Does it work? Oh, beautiful. Thank you. So yeah, they might actually ask you when the cartilage fuses. So also you'll get all these slides. There's nothing additional that I'm gonna say. So you'll get all of this. If you don't want to take notes, you don't have to. Yeah, they might just ask you when this fuses. So question 1, I'll give you like 30 seconds or whatever. Yeah, just discuss amongst yourselves. Okay, does anyone want to volunteer to give me like an A, B, C, or D or E answer? Did someone say D? And that is correct. Where are you at? This is not going to get there. Sorry. Maybe I should have allocated someone to this. Okay, so what's the nerve that he's trying to avoid, the GP? Sciatic nerve, good. And so because it's a really big nerve, you kind of want to know sort of what nerve roots it's derived from, and maybe where they split off, or like where basically the nerve is sitting. So a couple other questions. The first one, which muscle does the sciatic nerve pass under, and through which foramen? Anyone want to answer that? Just stick your hand up if you feel like answering it. Yeah, so it passes under the piriformis, that's good. And do you know which foramen? Sorry? Yes. And what does sciatica present as? Yep, so pain, that's good. So sciatica is basically the irritation of the sciatic nerve. And it can be because of quite a few reasons. So there's like piriformis syndrome, where it's passing through the piriformis, so the piriformis is irritated, and that irritates the nerve. The other thing that can cause it is like a slip disc. So a question they could give you is something like, this area burns and it has a shooting, burning pain down the back of the leg, and and they've tested these dermatomes or whatever, which is the affected one. So you'd know that it's one of the L4 to S3, and then you'd maybe have additional information to pick it out. So they might give you stuff like that. So just be careful. Okay, does everyone who answers the correct question just want to come down later and get the lolly? Because I don't want to kill anyone. Oh man. Oh no, here we go. Guess who doesn't do cricket? Okay. So guys, all right, so here's a bit of just a revision. So there's two important ligaments that form foramen. So that's the sacrospinous ligament and the sacrotuberous ligament. And so there's important like things that pass through that. So you can see that there's two foramen that are formed, and your piriformis and your sciatic go through here. Yep. And that's just something that Monash again has like really drilled in, especially last year. So maybe it might turn up. Also, I think that's spelled wrong. I think it's pudendal. Who knows? Okay. A patient comes in the hospital with crushing chest pain radiating to his jaw and left shoulder. The doctor decides that the patient needs a coronary angiogram but can't remember where the femoral artery is. He turns to you, the second-year medical student who is an expert at finding femoral arteries, for advice. You tell him the femoral artery is. Big hint, it's not E. Okay, do we want to do like a show of hands? For anyone who thinks the answer is A, stick your hand up. No hands for A? Okay. B? Okay. C? D? And I'm glad, I'm not going to ask you. I'm not going to do it. So, if you remember the, I think I have it in here. Yeah. So if you remember this sort of thing, it's nerve, artery, vein, empty space, or just like lymphatics there. So if we go back, if it's next to the femoral vein medially, it's actually the femoral canal that this is talking about. At the midpoint of the inguinal ligament, that's actually the midpoint between ACIS and the pubic tubercle, and that's not the femoral artery. It doesn't go over, nothing goes over the femoral, sorry, the inguinal ligament, nothing involved in this question. And the mid-inguinal point is where it's at. Yep. So this is a really, really big concept, again, that they push a lot in first year. So perhaps I think a good thing to learn would be the order of things in the femoral triangle, mid-inguinal point versus midpoint of the inguinal ligament, and the borders, so the floor, the sides, and the roof of the femoral triangle. Yep. It was a 2015 OSCE, and Year 1 Shmuley is nervously performing a lower limb MSK examination. She asks the patient to stand on their right leg and observes that their left hip drops downwards when they do this. Which nerve is impacted and on which side? Does anyone have any thoughts? Anyone want to volunteer an answer for a lolly? A lolly that I will not throw anymore.
Yeah.
Okay, and ta-da! You are correct. So if you go back, that sign is the Trendelenburg sign. So this could also turn up like in your clinical skills sort of part. So just make sure you know the clinical signs that you see and why they're there. And so it's damaged the superior gluteal nerve. And what's happened is that in a normal person, the gluteus medius and minimus will pull the pelvis this way so that the pelvis stays level if you lift your leg up. It's like a stability mechanism. When you have your superior gluteal nerve damaged, it can't do that. So you get a pelvic drop, but on the other side. So if they're standing on the right leg, the damaged nerve is on the right. If they're standing on the left leg, the damaged nerve is on the left. Yep, a really important thing to remember, because they're going to do this too. They'll just say right side versus left side. And it can feel a little bit confusing. Just remember it's the side with like of the leg that they're standing on. You have skipped 3 years of medical school and are suddenly an intern. A man comes into the emergency department with a traumatic injury to his leg. With your knowledge, you are able to diagnose him with compartment syndrome. What are the 6 Ps that can be seen in compartment syndrome? One of the Ps is not intuitive, so I will forgive you if you only get 5. So maybe this will help you. The traumatic injury to the leg is basically causing edema and swelling around the leg. So just think of if that was in a compartmentalized area, what that could do. Does anyone have any thoughts? Okay, someone give me 1. Yeah, pain, paresthesia, that's good. Pallor. So the leg's gonna change color. What's another one? Pulselessness. Sorry, I can't remember what else I heard. We're still missing 2. You're not gonna get one of them. I highly doubt you can get one of them. Okay. So parasympathetic, it's not intuitive. Yeah, it's a bad set of 6 Ps. But so the increased pressure causes pain because it impinges on nerves. It causes pulselessness because it impinges on arteries. Paresthesia, again, because of the nerves. Pallor, because if you've got swelling in an area, it changes color. Paralysis, because if the swelling is too much, it can impinge on the nerve to the point where you can't move anything. And perishingly cold, because you aren't able to get blood down to that area. So I used to struggle to remember the 6 Ps, but just think of like why they're all happening rather than just trying to memorize them. You are still an intern. A 68-year-old female presents to the emergency department after a fall. You notice some abnormal positioning of the limb and order an X-ray to confirm your diagnosis of a dislocated femoral head. What position is the dislocated femoral head in? Does anyone want to take a guess? Do you guys have any thoughts on which way it's positioned? A, B, C, D, or E? Okay, we're going to do a show of hands. A, B, C, D, and E. So this seems to be a topic of confusion, but it's posterior superior and internally rotated. So the trick to remember this is, do you remember dislocations of the shoulder? It's the complete opposite. It's like the opposite to the shoulder. So that's how I remember it, because the shoulder is the only one I actually remember. So a shoulder goes anterior, inferior, and externally rotated, and femoral head, so you can see here, it's dislocated posteriorly, it's gone upwards, so superiorly, and it's internally rotated, so you can see the trochanter is turned closer to like the front, so you know that there's been internal rotation. So you can get questions on this, and buzzwords would include like a shortened limb or shortened leg. Generally, the person that's fallen is a female. Generally, the mechanism is like a fall, or they're doing gardening and they've like fallen off the ladder or something. And it's generally someone who has reduced mobility, so possibly someone that's sort of in the older age range. You are somehow still an intern in the emergency department. A 78-year-old female comes in after a fall. You again suspect a problem and order an X-ray which shows a fracture. After taking a closer look at the type of fracture, you were concerned about necrosis to the femoral head. What type of fracture has most likely occurred, and what artery is disrupted? Okay, I'm giving you less time for this one. Does anyone want to volunteer an answer? Someone yell out an answer for Lolly. Okay, so I hear a B, and ta-da! So that was correct. And I found this to be incredibly helpful. So this puts the fractures and the blood supply side to side, and it sort of helped me understand what was running where and what things would be disrupted. So the medial circumflex artery runs behind, so you can see that there, and it provides the main supply to the neck and the femoral head. And so it's intracapsular, so that would be there. If you got a fracture there, anywhere there, it can cause avascular necrosis of the femoral head. If you get a fracture here, that's an extra capsular fracture. It won't disrupt that supply, but it might disrupt other things. And then you can have shaft fractures. So that would disrupt this artery here, deep femoral. So, but that requires a lot more force. But yeah, so just kind of remember what kind of fractures would disrupt what arteries and what would be affected. So I don't know how much this was like pegged forward in your year, but for us, this was a really, really big concept. And the way it was described to us was that the patient says that their knee hurts, but it's like lower than their knee, just slightly lower. And you can see that the insertion points are sort of a little bit lower than the knee itself, which is here. So the order of things is sartorius, gracilis, there's a bursa between that, and then there's a semitendinosus. And so the acronym, not really sure if it's called an acronym, say GRACE before T. So that's lateral to medial insertion points. And you can get bursitis, like over there. And it presents with swelling, pain, and tenderness. This is, I think, a little bit more unlikely to turn up, but it's worth just taking a look at anyway. You wake up from a really good dream and realize you are still a second-year medical student. Sorry. Whilst driving to uni, someone decides to tailgate you, and unfortunately, you've got to brake quickly, so they crash into the back of your car. You check on them because you're a nice person, and one of their passengers complain of knee pain. You, the expert at MSK knee examinations, perform one and realize that there is a torn ligament. Clue, think about which way the force is going. Okay. Does anyone have any particular thoughts? Just raise your hand if you want to answer the question. I don't like kicking people out. Anyone want to volunteer an answer? Yep. Who said B? That is correct. And I will get this to you in a second. So if you want to think of it this way, the force is being pushed again, is pushing the tibia backwards. So you've braked suddenly and your tibia's been forced into the dashboard or into some part of the car and it's being forced backwards. So the ligament that keeps your tibia stable and from like moving backwards is your PCL. If you put too much force on that, that will break. And so the way I like understanding injuries of the ligaments and the menisci is think about what movement it stops, and then if there's too much strain on that movement, that's what's damaged, and that's how it's damaged. So PCL is often like there's a car crash or something, so it's like a dashboard injury, and there's force from an anterior sort of direction, and it results in the posterior movement of the tibia. For the ACL, because the ACL is a lot weaker than the PCL, it's your most commonly ruptured ligament, and generally it's like a sporting injury, so someone will be playing like AFL or something, and so the buzzword will basically be that they've stopped to turn suddenly, or they've landed awkwardly, and there's like a pop, like a sharp popping sound, or like a twisting of the leg or something, right? And so those are the kinds of buzzwords that you might get for an ACL rupture. For the LCL, so you can see that here. This is holding together the lateral edge, right? So if you put force on it from the medial side, you'd put strain on that there. So if you get force from the medial aspect of the joint, you damage the LCL. Similarly, if you put force on the lateral aspect, the thing that keeps it stable is the MCL. So you'll get damage to the MCL. So do you kind of see how I'm doing this? Like there's absolutely no need to memorize this stuff. It's just think about how it happens and you can like forget it and work your way through it. Yeah. So what structures are in the unhappy triad and what kind of force, so like from what direction is it coming, which would cause the unhappy triad to tear? Okay, does anyone have any ideas? Just like raise your hand if you want to answer it. I don't like picking people out. Yep. Okay, which structure is best?
ACL and then medial collateral and medial meniscus.
Yep. And sorry, repeat the force, I just didn't hear you.
ACL, MCL, and medial meniscus.
Yeah. And which way is the force coming?
So it's generally the legs already hyperextended, and the force is coming from the lateral, so it causes the medial rotation.
Yep. So that's effectively what happens. So these, hang on, where are we? So that's your ACL there. That's your medial collateral ligament, which you can't really see, and your medial meniscus. So if you get force coming that way, basically put pressure on the MCL and the meniscus. And if your leg is already hyperextended, you put force on your ACL. And so they tear together. And the reason they all tear together and the reason why the LCL isn't involved is because, okay, all right, loud people. Right, so it's because those three structures are connected and the LCL is not. So remember that. They might ask you what three structures are connected or why the unhappy triad breaks together. They could ask that as well. The other thing is if you start to get questions on ligaments and you're like, I cannot for the life of me remember which ligaments there are, just think about what they're trying to protect and remember that they come in pairs. So your ACL goes like hands in pockets. PCL is the opposite to that, right? Then you have your lateral and medial collaterals, and they just run side to side. And then you've got your menisci, which are your shock absorbers. So just think of them in pairs. Don't forget there's always like a second one. You are studying for the VIA in 27 rainforest and look out the window longingly into the sunshine. You see a man walk past and notice that he has an abnormal gait. His left foot drags on the ground and he keeps lifting his knee higher to try and prevent this. Which nerve and muscle are affected? Anyone want to stick your hand up for a lolly reward? Sorry, did I hear an A from somewhere? Okay, and ta-da! That is correct. So your tibialis anterior, alongside other muscles, but tibialis anterior is your main muscle. It allows for your foot to dorsiflex. So if there's damage to the nerve, that allows this to work. So that's a common fibula. You get foot drop. So your foot literally just can't go up. So the person would basically get like a drag of the foot. Now to compensate, the person will try and lift their knee higher to stop the foot from dragging. The other thing that they can do is evert their foot. It's just like try and get it off the ground. Yep. And they can't invert it because look at the insertion point of the tibialis anterior. They can evert, but they can't invert. And yeah, so that's called your steppage gait. So gaits might be important to sort of remember. Another really, really interesting one is the Parkinsonian gait, where they have difficulty starting up. They start to sort of warm up and like shuffle their way forward. And then when asked to turn, they struggle to do that. So that's another sort of type of gait to maybe remember. True story. You are at home in New Zealand with your little sister. You want food but can't be bothered to get it yourself. You poke her on the lateral aspect of her leg below the knee in the hopes that she will make you lunch. After several pokes, you realize she can't feel anything there. Which dermatome is impacted? Anyone have any ideas? Thoughts? Volunteer an answer for a lolly. So someone has said L5 is. Anything else? Okay, so ta-da! So that was correct. So if you see here, a really important thing to learn is your dermatomes. This can come up again as like a subsection of lower limb stuff, a section of like a lower limb neuro thing. Another thing that you can do, which I just remembered, is that they can say to you, someone can feel pain here, but they can't feel light touch. So do you remember how, I don't know if you guys have done it yet, but there's like different spinal tracts that come down that do different things. They could merge those two concepts and say maybe on the toe they can do this, but they can't feel that. So sort of be wary of that. But yes, this is really, really important to remember. So I was looking through a lot of like images and books and things. There's not really a consensus as to which one does the big toe, like L4 or L5. So it's a bit of a waffly area and they might not give it to you. But S1, that's the little toe. So they could say to you, they can feel everything here, but not here. Yeah. So kind of know what separates the dermatomes a little bit as well. So if it's above the knee, it's got to be L2 or 3. And if it's below, it's got to be L4 or 5. Yeah? Yeah, and remember that S1 goes part way up the leg, but if it's like slightly below the knee or above, you know that it's probably S2 that's been impacted. So just try and remember the differences between the dermatomes, like the markings. No picture will give you the same set of markings. Just try and remember like something general that helps you. The other thing they can give you, and again, be very wary of like images, and I've just put this up to show you that they're not the same, not exactly the same as the ones that Monash gives you. So this is the set that Monash gives you of the lower limb myotomes. And again, this could be really important to remember. So a person could have decreased reflexes whilst, like in their knee. So which set of myotomes would that be? L3, L4. So they can put something like that up to you as well. And that's really, really important to remember. And again, it'll be important for your lower limb neuro if you get that in the OSCE as well. So yeah. Does this sort of all make sense? Yep. So I'm not going through like real detail. It's just big concepts that might come up, big concepts that might be likely. The other thing is the gait cycle. Yeah, don't forget that this is here. This is a really, really good picture because it sort of gives you an idea of, guys, it gives you a really, really good idea of what's moving, how it's moving, and when it's moving. So you can see that at heel strike, you've got these muscles engaged. At mid stance, you've got this one engaged. When you've got pre-swing, you've got these engaged. So this is a really, really good picture. Try and learn this. Also, pro tip, I was going to say secret, but not a secret anymore. When I was in my, I think it was end of year exam, and we had a question on the gait cycle, I obviously, for some reason, decided not to learn it. And then I sat in my exam room going, what on earth? How do I figure out the answers to these two questions? I watched the invigilators for 10 minutes. You can, because they have to walk around, right? They're the only people in the room walking around. So you can look at them. It's kind of creepy, but you can look at them and it works. So If all else fails, just be a creeper. Okay, and I'm actually done. So that's basically your big concepts. I just thought I'd keep this really short because you're not going to relearn every muscle and lower limb. If you've got any questions, feel free to come down, or any comments or anything. Just yeah, and good luck for your exams. Hope you get where you're wanting to. Also, come down and get a lolly because I've got some left. I did say we should.
Yeah, that was very concise. Very high yield.
I just thought there was no point in dragging you guys through stuff